So again, welcome everyone. Thank you so much for being here. My name is Jessie. My pronouns are she, her. I'm the co-president for Allies in Medicine for LGBTQIA. I have these amazing panelists here tonight, and then we also have our AIM-E board present. We're gonna get started, and I'm just gonna share my screen. Okay. And can everyone see this? Awesome. So again, thank you so much for being here. I'm going to kick off this event tonight with Dr. Birch. She is a professor here at Rowan School of Osteopathic Medicine. She received her counseling psychology PhD from Lehigh University, completed her APA internship and postdoc fellowship at the University of Pennsylvania. She is currently our course director for community service learning and leadership, and she's also the director of AHEC, which works with underserved communities in South Jersey, and she's a psychologist here as well. So I'm gonna turn it over to her, and we're gonna begin her.
Thank you so much. Well, I echo what Jessie said. We're so excited to be here tonight, and I'm so glad that you've come to this panel. So I'm going to be talking about working with the LGBTQ community and just some things to keep in mind when you do. You can go to the next slide. I think the first thing, though, to remember is that we are all in different places with this, right? So for some of you, this may be very new. For some of you, this might be familiar. For some of you, this is your everyday life and really definitely not learning anything, you know, particularly new. But I think the important thing to keep in mind is that there are no dumb questions. And really, we're all learning, no matter where we are with this. So I encourage you during this panel and anytime you're having conversations like this to just try to get comfortable being uncomfortable. You can go through. Yeah, you can just go to the next slide. Thanks. And you can just click through all the, go down all the, yeah. So I have a bunch of terms here, and I'm definitely not going to read off every one of them. I just want to point out a couple that historically have been misrepresented, if you will. So the main one I'm going to point out here is bisexual. Historically, people have thought, well, this must mean somebody is 50% attracted to men, 50% attracted to women, and that is it. And I really appreciate Robin Oakes' definition, who's a bisexual activist, and the definition she asserts is that someone who identifies as bisexual is someone who has emotional and or sexual attraction to both men and women and or other genders, but not necessarily to the same degree or at the same time. So oftentimes when I see somebody for therapy and they identify themselves as bisexual, my first question is, what does that mean to you? So keeping that in mind. You can go to the next slide. Great. So again, not going to read off all of these terms, but just a couple things to highlight here. So homophobia and biphobia, transphobia, that's increasingly being replaced with homonegativity, binegativity, transnegativity. And why is that, right? Phobia, if you think about it, is an irrational fear that's whether it's fear, claustrophobia or arachnophobia, right? Typically, people don't have fears of the LGBT community or fears that they're going to die if they see somebody who's not heterosexual or conforms to the gender binary. It's more about negative attitudes. So when you see homonegativity or binegativity, things like that, that's what they're referring to. And then coming out, right? This may seem like an easy one, and it, but thinking about coming out is different for everybody. In the media, we often see it as portrayed as like this great, wonderful thing, and it is. There's lots of mental health benefits. And for not everybody is it physically or emotionally safe to do so. So we want to really kind of keep that in mind with everyone we come in contact with. You can go to the next slide. So all in all, as nice as it is to maybe know a lot of definitions to a lot of different identities, language is always changing. And so more importantly than knowing every single word and every single definition is really approaching this topic and with patience with cultural humility, which really is just being open to learning, being open to being wrong, being open to knowing you don't know everything, right? I'm been doing this a long time, been giving this talk a long time, and I make mistakes and I identify as queer, right? So it's just kind of, it's more important that you approach a patient with humility than it is that you know exactly every definition to every word. You can go to the next slide. So just a little bit of history here. So the LGBT community doesn't necessarily have the best track record, or maybe it's the healthcare community doesn't have the best track record with the LGBTQ community. It was only in 1973 that homosexuality was removed from the Diagnostical Statistical Manual, which is a manual that has all different types of mental health disorders and different types of criteria. So like depression and anxiety is all in there. And homosexuality was actually, was a mental health disorder and considered pathological, really. So that was only removed in 1973. So even the term homosexual has a derogatory feel to a lot of people. And so I don't actually use that word unless somebody identifies themselves as that because of its negative connotation and its use to pathologize folks. You can go to the next slide. So while I think it's really important to know about historical context, I think it's also important to know that this is not history, right? It's happening right here and now. And in 2019, over 16% of hate crimes were reported to be due to sexual orientation. And just by looking at these numbers, what I think I can safely tell you is that they're completely off base, because reporting a hate crime automatically outs yourself. And for some people, that's just not something that they want to do. There's also can be a lot of guilt and shame. There could be fear of not being believed, or just kind of maybe experienced with law enforcement. And also this chart doesn't take into account intersectionality. So what do I mean by that, right? I mean people of different religions, races, socioeconomic status, and things of that nature. So often statistics, while helpful, we know that there's a lot more to the story. You can go to the next slide. So there's lots of different types of discrimination. There's the more explicit forms, and then there's the implicit and more subtle forms like microaggressions, which is usually an unintentional slight towards a marginalized group. So, for example, if I go to a doctor and somebody asks me, about my husband or boyfriend, right? It's like, do I want to come out here or don't I, right? And it's just kind of this, it's a pressure, right? And if you go to the next slide. And what research suggests is that both forms of discrimination, whether it be explicit or implicit, have really pervasive effects on physical health and mental health. So, and this has also been found in many different groups of people. So in terms of, it's been found across white samples, African American samples, Asian American samples, Native American samples, Latinx. It's a consistent link in the research that discrimination around these identities is linked to poor health outcomes and poor mental health outcomes, and just kind of some physical health outcomes that can be affected, or be seen in this community as increased rates of asthma, obesity, cigarette smoking, suicide, fewer lifetime Pap tests, less access to healthcare, and this is particularly with transgender youth, and delayed care. You can go to the next slide. So common barriers to healthcare or to accessing healthcare can be health insurance, previous negative experiences with the healthcare system. I know that if I'm working with somebody, even though I may identify as queer, I'm femme presenting, I'm straight passing, right? They may have had a lot of experiences with people that look like me, right? And so even though I didn't maybe cause that pain directly, there's still a history of experiences there. There might be a lack of specific research, policies, and procedures pertaining to LGBT folks, and then also may experience multiple forms of discrimination, right? So racism, sexism, heterosexism, and things like that. You can go to the next slide. So I think while it's very important to think about health outcomes and how discrimination can impact health outcomes, it's equally important to look at protective factors and the resilience of this community. So some protective factors meaning things that protect folks from negative health outcomes. One is collective action. So this can mean a lot of different things. It could mean joining a queer book club or being on a LGBT listserv. It could be going to, you know, a rally in Washington, right? It could look like a lot of different things. The main point being, it's about being with community and people who share similar values. Also, social support. The more social support is so key for so many things, and this is no different. Someone who's emotionally open to accepting and processing emotions, and then someone who has hope and optimism, and then also, again, coming out. Again, the caveat being to that is that, you know, coming out can be a positive mental health factor, but not always, right? And so we just want to be aware of that. You can go to the next slide. So what can be really important when I think about approaching anybody is using a cultural competence framework that comes from the psychology literature, but I think it applies to many healthcare professions. So really the main tenets being awareness, knowledge, and skills. So being aware of one's own biases, like what's my stuff? You can actually go to the next slide. What's my stuff? And yeah, you can click through. What's the emotional impact of my attitudes? What could that have on others, right? And so being really aware of that is the first step through and through. And it's okay to have biases. We all have them. It doesn't mean you're a bad person. It means you're a really good student. Anybody who spent any amount of time in the United States is not immune to this. I mean, we just get messages every single day. So it's just really being aware of it, because once you're aware, you can do something about it. You can go to the next slide. And you can go to the next slide. So another important piece to this is knowledge, right? So understanding the worldview of your patient, right? So this is by educating yourself and really understanding even the current social political system that your patient may be in every day, and learn about different sexual orientations, but one size doesn't fit all. Like I mentioned before, you know, two people can identify as bisexual, but that can mean completely different things. So really being careful not to put people in boxes. I mean, we do that. We do that for a lot of things, and we just kind of constantly have to remind ourselves to approach folks with an open mind. You can go to the next slide. And also, you know, as I mentioned in the last slide, just being aware of concerns that folks may face, whether that be family and parenting issue, custody issues, identity concerns, all things that can impact both mental and physical health. You can go to the next slide. Another thing to keep in mind is that, you know, an emerging model of sexual orientation is that it exists on a continuum. It's way beyond sexual behavior, and Lisa Diamond's research talks about sexual fluidity, that, you know, often people don't fit in one particular letter, right? We have all these letters, which is great. And it, you know, the longer the acronym gets, I think the more inclusive it is, which is wonderful. And there are plenty of people who are in between those letters, right? Who don't really feel like any of those fit them. And that's okay. You know, and also kind of remembering that there's dimensions of sexual orientation. So there's attraction. So who are you attracted to physically and emotionally? There's behavior. So who do you have sex with? What genders? And then there's identity, and that's how you identify yourself. And no one, no matter what behavior I participate in, no matter what my attraction is, only I can define how I identify, nobody else. So even if it doesn't make sense, you know, if a patient comes in and identifies a certain way and that doesn't match up with what you know to be true or what the definition you thought was, it doesn't matter. It's really how that person identifies. You can go to the next slide. So what can we do? So, we talked about awareness, knowledge, and then skills. Creating a welcoming space. This might seem so simple, but when I go into a doctor's office, I am immediately looking for signs that I'm welcome and that someone is going to be okay with who I am and maybe not make assumptions about me, whether that's a flag, whether that's magazines that are geared towards somebody like me, whether that's ads that have, a same-sex couple on it, right? It's just these little cues that I'm just looking for, even an intake form that allows me to put my pronouns on it, right? These little signs that this could be a safe place. I think establishing trust and rapport, critically important, and normalizing and validate and empathizing. Doesn't mean agree, but we can, even if we don't agree for whatever reason, we can normalize, validate, and empathize. And then again, reflecting the patient's language. What words did they use to identify themselves, and just follow their lead, and making no assumptions. I recently gave a presentation like this and someone said, well, there's just no way you can't make assumptions. And I thought, maybe that's true, but at least we can catch ourselves making those assumptions and pause and approach with, again, that cultural humility. Using gender inclusive language, try for a day just referring to everybody as they, them, their. And it just gets easier the more you practice it. And then again, being aware of specific issues related to LGBTQ communities. So what resources are in your area? What particular things might you want to keep in mind when working with patients like this? It may seem like little things, but they go a long way. And that's it.
Awesome. Thank you, Dr. Birch. And we will be having the Q&A session at the end of all the presentations. So if you have specific questions for any of our panelists, you can put them in the chat or put them in the form that we had where you can submit questions. All right, so we're going to begin with Dr. Wong. Okay, so Dr. Eileen Wong is a graduate of Yale University School of Medicine. She completed her urology residency at Stanford University. She's a practicing urologist in Pennsylvania, and a board member for Interact, a national intersex advocacy organization. She released None of the Above, a young adult novel about a girl who finds out she's intersex. Last year, she released This Is My Brain in Love, a young adult novel that tackles mental health in immigrant communities. We're really happy to have her on the panel, and she's going to begin her presentation.
Thank you so much for having me. I am still really impressed by everyone at Rowan and how they're giving you, by you, I mean the medical students, a level of education that I never had. I'll be completely honest. When I was at Yale, I maybe had about 10 minutes of my first 2 years dedicated to intersex, and back then all of my faculty members used outdated language that now is really stigmatizing and that many doctors prefer not to use. And so I hope that I really believe that you medical students are the future, and that you guys are the ones who are going to be the heroes of the future. So I'm going to share my slides now, hopefully. Now, let's see. No, I don't want to do that. I just want to present. So is that working for you guys?
Yep, it works.
All right, great. So I'm here to talk about the care of the intersex patient, and I say past, present, and future because I don't think that anyone could possibly go in to treat an intersex patient, particularly an intersex adult, without knowing about their past. Specifically, some would say the human rights violations that were placed upon intersex bodies by well-meaning medical doctors in the past. As Dr. Birch goes through, like mentioned in her talk, so many LGBTQIA patients come to our offices with like many layers of trauma, and so understanding this is going to be key in any interaction. So my key points, if you don't remember anything I say, just remember this. The first thing is that when it comes to intersex folks, words matter. I second Dr. Birch's suggestion not to assume anything, and not to be afraid of showing what you don't know, and knowing when to ask for help and when to just say, I'm going to look that up. And finally, this is something Roar is going to go into. There's the idea that there's this framework for conducting interactions with people called trauma-informed care, and that should underlie all interactions because, to be honest, most intersex adults that I know have been traumatized by people like me. I'm a urologist. I operate on people, and in many cases in the past, the operations performed on intersex children have led them to have severe complications in life. So first of all, I do want to emphasize terminology because, as I said, words matter. So in my talk, I use the word intersex because in my experience, it is the most widely accepted term for people with what is in the past been known as DSD or different sexual development. But essentially, intersex is often, as you know, confused with transgender, but it's not the same. It's a biological condition in which people are born with bodies that don't fit neatly into their understanding of what's male or female. And by biology, we mean chromosomes or internal genitalia or external genitalia. So the important thing to realize is that not all intersex conditions are identified at birth. Intersex is an umbrella term that encompasses a lot of different medical conditions, including congenital adrenal hyperplasia, epispadias, MRKH, Swyer syndrome. So where words matter and when you think about the history of intersex, where for so many years doctors used the term hermaphrodite, which is an extremely inaccurate and now stigmatizing word, where they used words like ambiguous genitalia, all of which are things that immediately suggest that intersex bodies need to be fixed. As I said, intersex does not usually mean transgender, although infants assigned the wrong sex at birth may identify as transgender later in life. Hermaphrodite is now considered a slur. There was previously a medical consensus that came up with the term disorder of sexual differentiation, but more recently, more progressive doctors have started using the term difference of sexual differentiation, which again is much less stigmatizing. And then finally, a lot of the community now uses the word intersex or consider themselves people with intersex variants. And words matter, like I said, and they matter because they affect people's response to their care. Instead of going into a doctor and expecting to be healed, many intersex people have gone into physicians' offices and had just a really negative emotional experience, whether it be because so much of the language that is used to describe their bodies is pejorative, words like inadequate or abnormal or disordered. So that's why I would really encourage you all to think about the language that you use, and interrogate your textbooks. Think that maybe instead of saying that you're the 17-year-old girl who visits you has a disorder of sex differentiation, imagine how their point of view might be different if they thought of themselves as having a difference of sexual differentiation, rather than using the term ambiguous genitalia, which brings to mind the whole, Pat the Hermaphrodite Saturday Night Live skit. Think about using the term atypical genitalia. And this is important because I truly feel that the treatment of intersex folks is one of the biggest ethical horrors of medicine. And it touches upon all these components of ethics, including access to care, need for a whole patient approach, not being heteronormative, in the past years, there's been a much rising understanding of the fact that intersex rights really intersect with human rights, because so many doctors in the past have practiced very paternalistic, dictated care when it comes to intersex bodies. The consent process for many childhood surgeries is somewhat fraught. And honestly, it could be a legal issue in the future. And then finally, medical professionals should care about intersex because it's not rare. It's just been rendered invisible due to shame and stigma. The number of people in the world who are considered intersex is a controversial number. I mean, the number 1.7 gets thrown around a lot, and which is, but in some respects, you could say that 1% of people have some sort of intersex trait, although not all people with intersex traits identify as intersex. And so this is a graph that does show how some of the more gray areas of intersex traits, including hypospadias, where the urethral opening is in a different location, or undescended testes, can be considered an intersex trait, which is very common. I don't know if anyone's specifically discussing trans care, but I know that for the past decade, people have been talking about the transgender health crisis, and I would say that there's similarly an intersex health crisis where there have been studies showing that 80% of intersex people have at some point changed their care because of negative interactions with providers. And that means that they stop going to specialists. That means that they go from a different hospital. And in each of those instances, every one of those disruptions of care, it makes it more likely that they don't go to see a doctor at all. Quick personal anecdote about how not to dialogue with your intersex patients. One of my intersex friends tweeted about this, how she just saw their urologist and told her that she wished she'd never had the surgeries she had as a baby, and their reply was, "Yes, you do." And that an example of, paternalism, the assumption that the doctor knows what is right. And it just goes to show that this is something that's prevalent. This happened, 2 years ago. And it's not just the historical medical provider that treated intersex patients poorly. So I think that I don't want to brush over the controversy about intersex surgeries, but I'm happy to address it at the end. So essentially, when I talk about the past, in addition to the language surrounding intersex, I also talk about the actual practices that medical providers inflicted upon intersex children, which meant that which meant that their diagnoses were concealed. Children were subject to repeated genital exams. And more often than not, genitals that were considered atypical but considered ambiguous, and as such a psychological and social emergency for the parents, they were often surgically assigned at infancy. Finally, and this is something that I'm particularly was exposed to as a urologist, many urologists removed so-called non-conforming gonads. For instance, someone with CAIS or androgen sensitivity syndrome who is technically XY but phenotypically is a girl, they would have their gonads removed because they were told that they were cancerous, when in fact the malignancy rates for that are very low, depending on the syndrome. But in other words, often they were coerced essentially into these surgeries. And doctors just really felt like they had to fix intersex children. But as a result, intersex children grew up with horrible complications from the surgeries that were inflicted upon them, including sexual dysfunction, painful intercourse, vaginal stenosis, and even possibly the most devastating thing was gender dysphoria, when they were assigned the quote wrong gender when they were born. And I would truly feel that medicine has failed the intersex community for a litany of reasons. But at the same time, you guys are all in a unique place because you, as the doctors of the future, are in a position to regain the trust of our intersex patients. And this is where I pass things on to Rory.
Awesome. Let me just pull up Rory's slides. One moment. All right, so I am introducing Roy Seymour. They are a second-year medical student at Jefferson School of Medicine, Thomas Jefferson University School of Medicine. They are an intersex advocate and graduate of Haverford College. They work to improve education on intersex variations and disabilities, and I will pass the baton over to Rory.
Awesome. Thank you so much, Jessie, for that wonderful introduction. And I also wanted to thank Dr. Wong for inviting me, and for Jessie also for inviting me to speak on this panel today. I'm really excited to share some of my experiences as a patient who is intersex, and really why intersex awareness matters in medicine. Next slide, please. All right, so I'm an intersex person first and foremost. I use they, them pronouns. And as Jessie mentioned, I'm also a second-year medical student at SKMC. But a little bit about my background and my particular variation. When I was born, doctors noticed that I had a solitary pelvic kidney. And so they thought that was a little unusual. And so they suspected that I had MRKH. And in 2014, I was diagnosed. And I'll go through on the next slide a little bit of that history and a timeline of those events, and highlighting key features where things really went south. And then since my diagnosis, I have been on a journey to embrace my identity and to advocate for intersex awareness in medicine. Next slide, please. All right, great. This slide is showing correctly. So I want to talk a little bit about the timeline of events in my life and really highlight areas where I think the healthcare providers could have done better. And at the end, I'll kind of wrap up and summarize some main takeaway points that I'm hoping you'll sort of bring away from this. So as I mentioned before, when I was born, actually October 23rd, 1997, so that's 2 days from now, physicians suspected that I had MRKH after finding that I had a solitary pelvic kidney. For those of you who may not be aware of the nomenclature, MRKH stands for Mayer-Rokitansky-Kuster-Hauser syndrome. It's basically this long list of names of the physicians that discovered this particular variation. And I think in medicine, we're starting to steer away from using names of folks to identify different medical conditions and steer towards using more appropriate language. So I think Valerian agenesis is also another name. But basically, what this means is that I was born with 2 X chromosomes, but I was born without a uterus, a cervix, and a vagina, as well as a solitary pelvic kidney that is associated. So because I had 1 kidney, every 2 years I had to get these renal ultrasounds. I just remember being like really resistant. I never wanted to go and get these ultrasounds. I was kind of confused because I was healthy, right? And I didn't understand why, I needed to go to the doctor, because that was where, sick folks would go and sick kids would go. And I wasn't sick. Like, why did I need to go? But then there was one time that I can really remember where the ultrasound technician the person who was performing the ultrasound made a kind of offhand comment that like, oh, I don't see your uterus, maybe it just needs time to grow in. And I was like, well, what does that mean? I was probably like 8 years old, and I didn't quite understand what that meant, and it wasn't really an appropriate interaction. My doctor wasn't there to kind of handle the situation, and I kind of was left kind of confused and not really sure what was going on. And then it wasn't until I was around 10 years old that I started having these exams to explore my genitalia. And that was sort of a really traumatic experience for me. There was this one situation that I remember where I don't really quite remember what began, what happened at the beginning and the end, but I do remember the exam portion of it and just being really confused and scared and quite frankly terrified of what was happening. I walked into the doctor's office, into the exam room, and was just instructed to sit up on the exam table, and I could see the footholds. They were called stirrups, and I just was like freaking out. I didn't know what was going on. And but I did what the doctor was asking. And he then proceeded to examine my genitalia, and like it was really painful. Like he was just not communicating with me at all. he was just, I was really tense and uncomfortable, and I just remember thinking, like, I just want this to stop. I don't want this to happen to me right now. Like, this is not okay. And I felt really out of control of my body and what was happening to it, and felt like I couldn't really say no. And he was communicating with my mother, but not me. And so I was kind of this third party, not really involved in that. And I just, was a really traumatic experience for me, coming away from that. But then it wasn't until around 2013 that my doctors, at this point, they didn't really find anything from those exams. I went through my medical records, I ended up getting them, and they weren't able to find anything substantial from those. But then I remember it was about when I was 15 years old, turning 16, my primary care physician mentioned the need for me to have an MRI. And I remember being quite confused because I was like, oh, well, why do I really need this MRI? And she would just kind of beat around the bush and not really answer my questions directly. And I thought, like, what's going on here? I immediately picked up that something was going on. And I thought to myself, well, if my parents aren't telling me anything, if my doctors aren't telling me anything, it must be really, really bad. It must be, something horrible. And I remember just trying to ask and trying to figure out what was going on, but I was mostly left in the dark. And so I ended up going through the MRI and just not even understanding why I was going through the MRI. And I was 16, and just, really confused, thinking that something was terribly wrong with my kidney, and, something was bad, and that they wouldn't tell me because it was so bad. And then it wasn't until I got to the gynecologist's office, and I actually thought he was a nephrologist. I was so confused. And I sat in the office and I was like, so we're here for my, my kidney, right? Because there's something horrible. I must have some really horrible disease. And I was really terrified. And he sat me down and said, no, this is something different. And he cleared up my confusion and sort of explained the diagnosis. And when the diagnosis hit, I was definitely like really shocked and upset and just really angered, and every right to be so. And at the time, I was like, okay, well, how can we, fix this? What can we do to fix this? And so I ended up going through dilation therapy. So for those of you that don't know what that is, it's basically where you take this plastic rod and you insert it into the place where a vagina would be, and you would create a vagina. And as I was going through that process, it was a very emotionally taxing experience, and it was emotionally painful as well as physically painful. And I just remember thinking, like, this absolutely sucks. And I just ended up stopping it. I was like, I can't go through this anymore. And it wasn't until later that I realized that I didn't even want that. Even though it was an option that was given to me, I didn't even realize that it was okay to just not have any sort of, intervention or proceed, like anything like that. I thought that, based on societal norms, that I was supposed to do this, I had to fix my body. And that was, a really damaging sort of not a stereotype, but a very damaging norm from society that I had kind of ingrained in myself, and unfortunately led me down to choose a wrong procedure, and it was really harmful. And at the time, the gynecologist also recommended that I reach out to MRKH support groups. I went to those, and they're somewhat helpful, but didn't really, there was something that was missing, and something that I couldn't really enunciate until in college. I started to explore my intersex identity, and I started to find out more about what being intersex meant, and really started to embrace that identity and embrace my body. And then that was the moment that I started advocating for intersex awareness. So if we move to the next slide. Yeah, so just a quick overview. So in college is when I started my intersex advocacy work. I was at Haverford College, and I worked for the Gender Resources and Sexual Education Center. And I was trying to build more awareness of the, just more intersex awareness and awareness of what intersex, being intersex is and the challenges that intersex communities face. And so I hosted Pigeon Magonis, who is a really well-known figure in the intersex community, and I invited them to campus to speak about the importance of trying to advocate against non-consensual, medically unnecessary cosmetic genital surgeries that were being had on intersex folks. And so I'm happy to talk about my experiences there as well at the end. Next slide, please. So what are really the main takeaways that I'm hoping you'll come away with? Well, I think for one thing, the importance of really promoting a healthy physician-parent-patient relationship. I think that, in a lot of points in my story, there was a lot of areas where that relationship really broke down. And I think that if things had gone differently, that relationship may have been intact and I would have had a better experience. But if I could have the opportunity to go back and tell my doctors, well, here's what you could have done to help me and to help improve the situation, what would that be? And I think there's really three main things to that. I think the first one is to promote open and honest communication. So making sure that you're not concealing information from me and that you're including me in the decision-making processes and not keeping me in the dark about everything, which was what ended up happening, right? And really double check that I fully understand what's going on. Don't just assume that because I'm silent that I'm okay with what's going on or that I understand, because I really didn't. I was silent because I was confused. The second part is the importance of advocating for my autonomy. So really making sure that you obtain my assent before and during a genital exam, right? And clarifying to me, I will do my best to respect your privacy and autonomy, and really communicating that if there's anything that makes you uncomfortable during this exam, please let me know and I can stop what I'm doing. I think if those things had just been said, things would have gone a lot better. And just, even just knowing that it's okay to say no, right? It's okay to say no to this genital exam. Like, you have power over your body and to say no and to consent to those procedures, because you do. It is within your power to consent. And then the third thing I think is really to understand how societal norms may influence decisions. I think that's really important for me, where I kind of went down the wrong path of trying to fix my body when it really didn't need fixing, because I was pressured from society to feel the need to fix it, right? Because I was supposed to be this person and I wasn't supposed to have this, right? So and that really comes down to having more awareness of intersex variations and more acceptance, right, of intersex folks and for differences in sex development. So I think those are the three things that if I could go back and say to my doctors, I would say, here are the three things that you could have done to improve the relationship with me. And if we go on to the next slide, I just want to summarize a few points that you can do to help support intersex patients. I think the first and foremost thing is to really listen with an open mind. Try and do away with any preconceived notions that you have about what it means to be intersex, and really just listen with an open mind and don't make assumptions. Like, please don't assume that when I walk in and I may sound a certain way or look a certain way, don't assume that I menstruate every month. Don't assume that I can have kids. I mean, that's happened to me before, where the first question that someone asks me is, when was the date of your last menstrual period? Over time, I kind of found clever ways of responding to that question, but it's just really rude and inappropriate. So just make sure that you are, approaching the situation and not making assumptions and looking at my chart, because you'll find that it has the information that you need to not make assumptions. And also educate yourself on the challenges faced by intersex communities and the harms that they've faced in medicine specifically. And I have a resources slide at the end that you can look through to help educate yourself. But if we, just quickly going back to the last few points, or the last slide, I just want to reiterate the importance of checking in with your patient during an exam, and especially the genital exam, and ensure, double check, triple check that you have their consent before proceeding. And then empower the patient to play an active role in shared decision-making, include them in the decision-making process, explain to them what's going on, and really making sure that you empower them to take control of their health. And then also, I also wanted to bring up the importance of using a trauma-informed care approach. So for folks that don't know what this is, it's basically an approach that basically is recognizing that a lot of people have gone through traumatic experiences in a lot of different ways, and it's making sure that you're actively resisting re-traumatizing an individual. And there's a few key principles of a trauma-informed care approach, but I think the most important ones are to build a safe environment. So make sure that you're doing things that signal to your patients that your environment is a safe location where they can communicate with you and be open and honest with you. The second part of that is to, right from the get-go, try to build a trusting relationship with your patient. So respecting their identity, not making assumptions, all right? All of these things go into establishing a trusting relationship with your patient. And then there's some other ones, right? Making sure you're collaborating with your patient and including them in the decision-making processes and empowering them, again, to make decisions. I think if you can kind of keep those approaches and those things in mind, I think things can go a lot better, at least in my case. And then the next slide, I also want to speak a little bit about why intersex awareness is needed, specifically in medical education. I mean, obviously we speak a lot about educating doctors and, about a greater awareness and things like that, but I think we also need to target our approach to medical students as well. And being a medical student, I mean, I've definitely seen the ways that doctors will be talking about and using language to describe something, and then medical students will sort of take on that language and will be socialized into accepting that language. And I've seen that actually happen and play out in terms of language used to describe intersex variations, where doctors will be using inappropriate stigmatizing language and then students will pick up on it, right? And so I've had to educate students about appropriate language use, and take time to really start the conversation because of a few things that professor said, right? So, and I think stemming from that, if we can start to build a greater awareness of intersex variations in medical education, it also will help intersex folks as well, right? So if we can allow medical students to be more aware and to help them be advocates for intersex patients and say like, hey, maybe next time it wouldn't have had to have been me, the intersex medical student, who needs to educate that person. Maybe this other medical student could have stepped in and said, hey, well, that language use is really inappropriate. Well, here's more appropriate language that we can use to describe that particular variation. And it takes the burden off of intersex folks from having to do that educational piece, right? So I think those are the main points about that. And then I believe that's my last slide. Yep. And then this is just a resources slide that I put together of some resources if you're interested in learning more about sort of intersex advocacy efforts, as well as clinical care guidelines for affirming care for intersex folks. So Interact, which is a youth intersex advocacy group, I just have their link there. There's also this really in-depth report in 2017 that highlighted, there was a bunch of interviews that culminated in this report that was generated, and it really highlights the harms that intersex folks have faced in medicine. So if you're interested in looking at that report, that's the second bullet point. And then the Affirming Care for Intersex People 2020, it really is a great community-informed clinical guide that helps clinicians to think about how to promote and how to provide primary care that is inclusive for intersex folks. And that is all. Thank you very much. And I'm happy to take any questions at the end.
Thank you, Rory. I will now be getting ready for Dr. Cohen's presentation. And then after Dr. Cohen will be Dr. Winters. and then the Q&A is after that.
Okay. So thank you so much for having me. Should I start?
Yeah, let me just introduce you,
Oh,
sorry. So just wanted to introduce Dr. Solomon Cohen. She's a pediatrician at the CARES Institute here at RowanSOM, and she's the program director of Child Abuse Pediatrics Fellowship. Her expertise is in caring for youth who have experienced child abuse, neglect, children in foster care, human trafficking victims, and other vulnerable populations. So without further ado, here is Dr. Cohen.
Okay. Thank you so much for having me, everyone. I just so in awe of all the panel and everybody who's spoken so far. So thank you. And I have to apologize. I had a filling on my teeth earlier in the day, and it has not worn off. So I apologize if I trip over any words. But okay. So you can go to the next slide. All right. So when I was a medical student, I always thought it was so helpful to kind of know who was talking and what was happening. And it's just, I feel like it was nice to kind of see myself in some people who lectured, or at least to know background. So I'm going to tell you a little bit about my background. So as you can see, I was in college, I was an English major and econ minor with the intent of tearing down the economic system. I did not succeed at that. And I went to medical school as an older medical student at University of Maryland. I was a pediatric resident at UVM, and then I completed a 3-year child abuse pediatrics fellowship at Brown University. And child abuse pediatrics, you can go to the next slide, child abuse pediatrics is actually a subspecialty of pediatrics in the same way that GI or pulmonology or pediatric cardiology is. It's a 3-year subspecialty fellowship, and then there's a board certification at the end of it. So that's what I did. I work at the CARES Institute, which is one of the many centers and institutes at Rowan Medicine. And at the CARES Institute, it's called the Child Abuse Research, Education, and Service Institute. And there we evaluate kids when there's concern for abuse and neglect. And we also have a foster care clinic there. And what I'll say is, I just so appreciated what everyone has said so far about trauma-informed care, because that's really what I do. That's what we do in particular for kids who've experienced abuse and neglect. And I see myself as a person who can empower people whose power has really been taken away from them. So I actually celebrate when patients tell me no, I don't want the genital exam today. I want to come back for that later, or I'm not comfortable doing that right now. Or when they say, wait, I don't understand what you're talking about. So I actually make patients practice with me to say no. And I also make them practice saying, wait, I don't understand. Can you tell me that differently? Even the littlest of kids, before I talk to them. Because to me, that's one of the most important things as doctors, both in child abuse, but also in general. Because I can, I think everybody has had the experience of being a patient. And even in being a medical person, it can be overwhelming. So just imagine if you're not medical, if you're in some way already disempowered or underrepresented in the office in which you are sitting. So go on to the next slide. So I do, as I said, work with vulnerable youth, and my passion is their health and well-being. You can click next. Oh, it's shrunk so much, but you can go, yeah, there you go. And to me, one of my biggest passions and interests is LGBTQIA patients. I'll also say, I wanted to say this before, I'll back up and say that my pronouns are she, her, and I identify as queer, and I have a wife and 2 children and live in West Philadelphia. Okay, so many of you know the statistics, I'm sure, about pediatric patients, or about patients in general who are LGBTQIA. Maybe some of you don't. So in terms of pediatric populations, LGBTQIA identities are actually incredibly common. And I'll say that many of my patients who may not identify as LGBTQIA actually are still thinking about their identities and their behaviors. And the most recent study I saw was in 2019, which said that up to 16% of youth identified as LGBT or Q. That was a study that they looked at, those terms that they looked at in this study. And that's a lot. And another study showed up to 2% of people identified as trans. And of course, this is an underreporting. These are the pediatric populations. What we know is that children and adolescents on average come out to peers or to adults in their lives at around 16, but many know ahead of time, or at least are thinking about it ahead of time. The other thing that we know for kids in this population is that kids and adolescents in this population is that they have a high incidence, as adults do, of depression and suicidality. And I'm particularly mentioning that because this is a mental health emergency, in my opinion, and now also the AAPI just recently identified that there's a national mental health emergency for all children. And I would say the vulnerable populations are at the highest risk. We know that there's one study that shows that 75% of LGBT, lesbian, gay, and bisexual youth and adolescents identified as being depressed in the past week of the survey that was done for this study. Another study shows that youth who are LGBT have a 3 times higher likelihood to attempt suicide. If you look at trans youth, the numbers are even higher. Trans youth are 6 times more likely to be depressed and 8 times more likely to attempt suicide or to have suicidal ideation. And in fact, 35 to 40% of trans youth in another study identified that they had attempted suicide in the past, which is just an incredibly high number. You can go on to the next slide. So what about victimization, this is my wheelhouse. So what we know is that this is youth who are LGBTQIA are just vulnerable in many ways. We know that lesbian, gay, and bisexual adolescents are 3 times more likely to report childhood sexual abuse and 1.3 times more likely to report physical abuse. And I would, in my subjective experience and also in other data sets and literature, the incidence is actually higher than the reported. Than what's reported, of course. And what we know is that the disparity in sexual orientation groups are greater in males as opposed to in females. In other words, male LGBT adolescents are even higher likelihood to have sexual abuse or physical abuse in their experience than identified heterosexual, as opposed to the well, in this population they were just looking at people who identified as males and females. So you can go to the next slide. And for trans youth, we know that the risks are high as well, 1.4 to 2.6 risk for being sexually abused and physically abused. And youth who are self-reported as having a higher level of gender nonconformity are actually at highest risk for victimization. The other thing that I'll say is that we know that 20 to 40% of homeless youth are LGBTQIA, and that population is at risk for many health sequelae. Go to the next slide. One more thing to say about youth who are LGBTQIA is that the relative risk for to be assaulted when they're in school is very high. So there's one study that showed 7 times more likely to have an experience of assault in school. And when you look at youth in New Jersey in particular, 80% of in the most recent transgender survey, which was actually 2015, so not so recent at all, 80% of people who identified as trans identified that they had been bullied in school because of their identity. Okay, so going on to youth in foster care, we also know that LGBTQIA youth are more likely to be in foster care than those who identify as heterosexual. So 20 to 35% of youth in foster care identify as LGBTQIA, which is over 20,000 youth, and I would say probably that it's more. 7% of this population are trans or gender diverse or gender fluid. We know that these youth are more likely to be in congregate care or group homes, and that they're more likely to be identified by Child Protective Services as difficult to place. Next slide. So to me, when I do my foster care clinic, I don't see these kids, or if I do, it's because I really pursue them. I really, really encourage caseworkers to bring them in, but it's just they're not identified. And I think that's probably for a variety of reasons. So one of the things that I hopefully will do in the near future is really think about ways to broaden the medical space for youth and adolescents who are LGBTQIA. We know that there's like a healthcare desert in Southern New Jersey for these youth. We also know that gender medicine care for trans patients in Southern New Jersey is very, very difficult to access. There are clinics, of course, at CHOP and Nemours, and there's one in Rutgers, but that's pretty far north. There's one at Cooper, but that's really only for adults. So that's another really big gap that hopefully will one day be filled. You go to the next paragraph. One thing that we're doing right this second that I hope can be expanded to other practices is that we're trying to think about how do we change our healthcare environment, our physical environment, and our cultural environment. Because at CARES right now, we're just kind of like an office with some kid-friendly things, but we're like an office. So go to the next slide. So the pictures went away. If you click one more time, will the pictures come up? Oh yes, look at that. So the things that I'm thinking about what to change in our office setting is, first of all, the physical environment. So putting up wall decorations, posters, having books that are available that reflect our patient population. So that means for kids who are LGBTQIA and also kids who are BIPOC, because that is always a dearth in all of the waiting rooms that I've ever been in for children and for adults. The other thing to think about that I've thought about a lot is how do we identify ourselves as allies, as physicians, and also how do we easily identify our pronouns. So that's something I think that takes practice, as other people have talked about, and also I think there are ways to do it in a subtle way. So UCSF has this example where they have Electra Abundance, Mother of the House of Abundance, and you can see the pronouns on that ID. And the other things that we are actively thinking about are how do we ask our patients about this? And I'll say that I wasn't in medical school all that long ago. Maybe it's been over 10 years now, but still not that long ago. And what I learned, just like what Dr. Wong said, was it's incredible how limited it was. And my guess is that it's much better now, but maybe not perfect. And so I remember learning about how you ask about sexuality and identity, and it was abhorrent. So it's something that we old doctors, and I'm an old doctor, we're still trying to figure out. So I think about things in terms of, I see youth and adolescents, so I often will say, well, now you're a teenager, so like, what do you notice about being a teenager? And sometimes they'll talk about, oh yeah, well, everybody's dating around me or something, and I'll say, oh, like, have you been thinking about that at all? Or have you done that? Oh yeah, oh, well, who are you into? Or like, who are you attracted to? So that's one example, but there are many other ways to ask about identity. And I also actually just ask about identity, sexual identity, gender identity. Okay, the other things that we are thinking about are how we gather information from our medical records regarding identity, and how we then store it in medical records. But you could go to the next slide. And one well-known way to do it is to make sure questionnaires that are healthcare questionnaires have, it's a two-step gender and sex differentiation set of questions. This is one example, it's the most simple example, where you have the name, the gender identity, and the sex assigned at birth. There are lots of other ways to do this that are more complex and probably more inclusive next slide. Oh, so when I was thinking about, learning more about how to be a better medical provider, specifically for trans youth who are needing gender medical care, and that's a broad term. It was very helpful to kind of know at least places to start. So I wanted to list a few. I can offline give you the actual links and connect you to actual people who do this work as well. But Mazzoni in Philadelphia just has a great conference every summer about gender medicine and wellness. The WPATH is a great organization. UCSF has a bunch of protocols. And then the AAPI actually is doing a better job with getting data and policy about treating LGBTQIA youth. So I think those are all my slides. Thank you so much for having me.
Thank you so much, Dr. Cohen. So unfortunately, Dr. Winters had to step off. He had a family emergency. So we are going to begin the Q&A portion of the panel. And I will just pull up the questions. And some of them are for everyone, and some of them are for particular panelists. So let me just get those going. Okay, so the first question is, what do you think as a medical student we can do more to help the LGBTQIA community? And that one is specifically for Rory.
Is this coming from current medical students, I'm assuming, or?
Yeah, this is from medical students.
Okay, I think is the question about LGBTQIA plus populations in general, or specifically intersex?
It wasn't clear, but it said LGBTQIA. So.
Okay, I think one of the things that I've noticed as both an intersex person and as a medical student is in medicine, we're currently at a point where we're starting to be more aware of the healthcare needs of trans populations and LGBTQ populations, but not necessarily I populations. So I think in a lot of the spheres, intersex populations are often left out and are left out of the acronym. So I think one of the things that's important to do is recognize that intersex people, may identify as LGBTQ, but, we also need to be advocating for them as well in our advocacy efforts and make sure that we're not just leaving them out and, really doing the work to educate yourself about the things that they face in medicine and, trauma-informed care and how to really think about applying that to your own practice. And I think, even just like spreading the word out among medical students and like if there's opportunities that you have to present to other medical students or, just have conversations, I think that can go a really long way, especially if folks are really receptive. I've had good experiences with talking with, at least from my experience as a medical student, talking with other students, and it just kind of seems to spread. So I hope that answers the question.
One thing that I kind of want to interject, if you don't mind me sharing my slides again, is that I have a section on medical research, particularly like not only intersex specific, but any facet within LGBTQIA care. It's a vastly underserved area, and it's in an amazing niche for medical students to get into if they want to make a career out of it. I mean, I know several people who started off as medical students and then went to fellowship, and like that is their niche, that is their the place that they have carved out in the world. And there's a lot of room for advancement and grants, and particularly because it involves thinking in different ways. And I'm going to share my slide really quickly if I can. But so I think, so so I'm, as you may or may not know, I am kind of a controversial figure within the urology community because I've been very critical of my fellow surgeons who have been doing, work doing surgeries on intersex kids, and they say, oh, well, there's no data to support, whether kids aren't going to be harmed by not doing surgery. And I'm like, you never had data showing that doing surgery would help them in the first place. And so the issue is that the data surrounding most intersex is horrible. I mean, I don't know if you guys are at the point where you're doing journal clubs yet, but shoot, where am I? I actually didn't put my slide in there, but the research that people are citing to support the use of intersex surgeries involve ends of less than 100. They're all involving totally different diagnoses. There are no randomized clinical trials suggesting that surgeries help intersex kids. None. And so many of these quote new better practices haven't had studies showing long-term outcomes. And so this is the opportunity for you guys as medical students to get to a point where you can contribute in that realm in the terms of creating research studies that actually reflect the issues that intersex people care about. Because so many of these studies that are out there are focused on cosmetic appearance rather than functionality after surgery. They focus on parental distress rather than on the psychology of the actual child whose gonads are being removed. And so the movement within the intersex community is to involve the community in research. And by doing that, by gaining the trust of the community, you can create a new type of research, what's called created community-based participatory research. And specifically by identifying and eliminating a lot of implicit bias in some of the current literature out there. I mean, science has to be objective because intersex care has become increasingly political. I've testified in state senates, and the president of the Society of Pediatric Urologists said on a talk radio that militant LGBT activists want children to be happy to be who they are. And they are branding the legislation to protect intersex children as being anti-choice and anti-parent. We're completely neglecting the child's choice and completely neglecting the fact that their science is negligible. Like their data, they have nothing to prove their point either. And so much of the literature out there has design bias, in other words, not asking the right questions. They have selection bias and that they cherry pick the patients they want to report on. There's response bias because most intersex people don't even want to have anything to do with any medical professional or researcher to even be involved in any of these surgeries. So I could go on, but specifically that is what medical students can do right now because you guys have the time, you guys have the energy to do that. So go ahead and do that.
Thank you, Dr. Wong. The next question is for everyone. It kind of was talked about throughout the panel, but the question is, what improvements or interventions have been done to improve healthcare for LGBTQIA+ populations in the last 10 to 15 years, and what else can be improved going forward?
I was gonna be glib and say Twitter was actually really important for and like the internet is really important for the intersex movement because it allowed people to realize that they weren't alone. But I think that's really true. Also, the idea of an organ inventory, which is Dr. Silman Cohen was talking about, asking what their gender at birth was, what their gender now or sexuality is now, and you can actually go down and say, okay, what organs were you born with and what procedures have you had? And so taking gender even out of the equation and just talking about their bodies.
Yeah, I definitely agree with that. I mean, there's been numerous times where on medical forms, like the only boxes that I have to check are either male or female. And it's like, well, which box do I check? And like, if I choose one, then they're going to assume that I have all these organs and, you know, and experience these things and are going to ask questions and just go down a completely wrong path. So it's like, how do we make our medical forms, you know, right from the get-go inclusive towards intersex folks? And exactly, so having some sort of inventory and say like, hey, like, what is your anatomy? Like, what, you know, what organs do you have? I think could be really, really helpful, particularly for intersex folks.
Awesome. I'm not sure if anyone else had anything to add. We do have a lot of questions, so I'll move on to the next one. With the laws in states in the South specifically targeting trans youth, preventing them from receiving affirming care, is there a way to support providers and patients from here? And that's a question for everyone.
I would say probably what's obvious, which is money and voting. Another thing that I'll say, I've been thinking about this a lot because it affects a lot of my pediatric colleagues in particular. Well, not only in particular, but like these anti-LGBTQIA laws have been in like over 30 states, even in the last year. But I read a statistic showing that actually there's also a high percentage of people who oppose things like the sports bans and who want people to have equal access to medicine. I don't know that anymore. But that there's like two things happening in some ways, that it's like a small minority of very loud people who are making these laws happen. So something to remember, that all of our voices are really important. The other thing to say is that places like groups like the AAPI, I'm sure some other professional organizations are trying really hard to combat this through different advocacy efforts. So it's always worth that. That's only a piece of the puzzle.
Yeah, going off that, I would say see what the activist groups locally in those areas are doing, right? Like maybe there's and see if you can join with them somehow, right? Because chances are there's already people in those areas doing the work. So then calling them, emailing them, hey, this is who I am. I would really like to help. What can I do, right? Because they're the ones that are going to know better than anyone, rather than people, and we, you know, coming from the outside thinking, you know, right, we want to see what the community itself is doing and then see how we can assist, you know. And maybe that's writing out like 1,000 postcards to remind people to vote, right? I mean, so just yeah, seeing and doing some, you know, searching to see maybe there's a you know, specific community or a local organization you can support.
Thank you. The next question is, can you recount a time when you had a good experience with a physician or other healthcare provider? What made it a good experience? This is for everyone.
This is telling, right?
I know. Not a good sign.
My silence is more about, not that I mean, I have been lucky. Well, here's the thing, right? I'm femme presenting, I'm white, I'm straight passing. So you can't see like who I live with. I mean, you can't see my history in that way. So I have been lucky in terms of not getting the explicit looks or words or what have you. It's more implicit, right? It's the assumption, and it's the time. I mean, I go to the same doctor every year, and it's like, really, look at my chart. I know I wrote this in somewhere. You know, it's like it's like it's not awful, but it's not. It's just kind of taxing. You know, but I would say, you know, and I think Rory, this was in your presentation, and I remember my partner saying something similar, like when going to get an exam, like every step of the way, like, is this okay? Is this okay? And referring to, you know, not using gendered terms for body parts, right? Chest instead of breast, right? It's just it. And like, I just remember my partner coming home and being like, oh gosh, she really knows what she's doing. And that, you know, I mean, so not to steal their story, but I just did. It's okay, they're fine with it.
So, oh, okay. A little bit of feedback on my side. I think a really good experience for me was when I had to go to get my IUD replaced. And so as a trans man, it was something I was really, really anxious about. Like, I was not looking forward to going to the clinic and saying, hi, I'm here to, you know, address my reproductive health in this way, and then have all of the assumptions that I was used to experiencing then applied to me and applied to my visit. And I was really surprised that day because the nurse who brought me back and was taking my history and such, when I told her, hello, my name is Duncan Holmes, I use he, him, his, just didn't bat an eye. Like, it was very affirming in that she was like, okay, cool, like, didn't like phase her at all. And so it didn't feel like it was a chore for her to just change her behavior. It was just like checking a box. It was like, okay, it's like, okay, your address changed. Cool. It was very, it was really huge in that it felt so small to do it, you know, like it. And then I didn't have to do it for everyone who came in. She was like, okay, I'll make that note. And everyone who came in then knew how to refer to me, and was very, very kind and affirming in that way. And so I think that speaks volumes to like our common thread now of just the importance of communication and the importance of getting consent and asking your patient how they want to be treated and how they want to be referred to.
Thank you, Duncan. The next, if anyone else wants to share a positive experience, they can. But if not, I will move on to the next question. This is for everyone. How would you change the current curriculum to better prepare medical students to care for LGBTQ+ population?
Well, I would definitely make this presentation a required part of the curriculum.
I'm already on it. I have an email ready for you, Jesse, for my LGBT panel and CSLL. But I think that there just needs to be more required, like something like this should be required. I think training with faculty and staff, right? Because as some people said on the call, like not everybody has had this training, right? And it is what it is. It's not good, but it's just what it is. So, you know, being able to, offer training, just having more classes that are dedicated to underserved communities, and also not just that, but having this stuff incorporated in every class, right? Because this is important everywhere. Whatever class you're in, somebody's identities are important, and having that like seep into all aspects of the curriculum. Yeah.
I know that Rory was and their counterparts at Jeff who were doing the clinical training, like actually had a practice patient, I guess. I don't know what they call it now, but a standardized patient who was intersex. And I think that is a really invaluable experience to actually have be forced to be role playing these kind of questions. Because once you go through that discomfort once, you're going to be so much more able to do it later on, and to be introduced to actual real LGBTQIA people, like that, to see a trans person talking about the things that can trigger them in the offices, to hear Rory talk about all the ways in which medicine has failed them. There's the things that I remember the most from medical school were always the times when patients actually came into each other's stories.
Yeah, I definitely agree. And I think particularly with this clinical skills part of it, I don't know about everyone else at Rowan, but at Jefferson, the way that we learn, especially about like taking a sexual history or like just like the sorts of questions that like we're learning about, like that we need to be asking, aren't necessarily inclusive for LGBTQ folks. And I think like having and carving out specific space where we evaluate those questions and say like, hey, well, maybe we could ask these questions in a different way or elicit this information in a different way and use a different approach, because some of the questions where it's like you're just assuming that someone has these organs and has this particular biological function, and then the questions that you ask, you just go down this pathway and it's like, well wait a minute. A, you didn't even ask the person what their gender identity was, and like B, you didn't ask like what sorts of organs they're born with. So it's like, how are you going to know how to connect with the patient if you're not even setting the stage for like how to interact with that person and like what things you need to be keeping in mind.
Thank you so much. These are great responses. The next question, this is for everyone. What aspects need immediate help on campus or in the area?
I feel like there's like lots of thoughts happening at one time. Like, which one do I pick? The first thing I thought about was visibility, right? I mean, just again, when I was saying before about like when I go into an office, I automatically, I'm just looking for clues like that, like this is a welcoming space. So I think visibility not only of like signs and pictures, but faculty and staff that represent, I mean, not just the LGBTQ community, but other marginalized communities. I think, and more than that, right? Just having more education, because I think what I have, I mean, this is my sense, is that if folks weren't trained in this area or don't know a lot about it, then they get uncomfortable talking about it, right? And so then they don't talk about it, or like it's like I mean, I hear it so many times. Oh, we talked about an a gay man, but he had HIV, and I'm like, oh, like, or they're like putting together these like stereotypes, and so I think just more education, more mandatory, like maybe professional development, but it's really a culture change, because I think it's a commitment, it's an attitude. It's not so much like, oh, if I have all this knowledge, then I'm going to be great. No, you have to feel it. You really have to believe that this is important, and that takes time, I think, for a culture change like that.
Yeah, just to sort of add on that is I think that like just having the faculty, like Dr. Birch, obviously amazing, wonderful, I love you, but having just faculty for all of our lectures, you like take some sort of training and use that gender inclusive language and integrate all of that into just all just across all of the specialties and across all of the blocks, just I think not only makes it a more integral part of our curriculum, and makes it so that we're constantly thinking about it. It also like will help dismantle like the connections that we might have made just because like your only exposure to, like as you said, the like someone who is like who identifies as a gay man might be the HIV crisis. And so if we integrate it into each block, it becomes, oh, I know how I can care for LGBTQI patients across all of the spectrums of issues that they could present with, because we can all present with the same issues that everyone else can. And so I think it's really important to just the culture change, but also the language change, and like making sure that that it's integrated into how everyone gets educated.
I agree. Integration is key. Thank you. The next question is, can you tell us about your experience with patients and interacting with their parents that may not know about or accept their respective identities? And that is for anyone.
So I can talk about this. I think about this a lot, both because I see kids whose caregivers are not their permanent caregivers, their resource care or foster care, and also because I see a lot of patients who are not out to their parents. So I'll tell you what I do, and I'm sure everybody will have things to add. I will do it separately. So I speak with caregivers and patients separately. I'm very, very lucky. So I'll talk with caregivers first. I'll ask them about their concerns. And then no matter how old the child is, unless they're not verbal, I talk with them alone. And whenever I do that, in my introduction, I always introduce myself. And then I always ask them about themselves. And I do often, when I introduce my own pronouns, sometimes people will then tell me theirs. And then sometimes when I'm asking them about their health, they'll tell me. And my first question is always, oh, okay, well, like, how has that been for you? And do your whoever, parents, grandparents, aunties, whatever, do they know? Oh, like, what do they think about this? Or what do you think it would be like if you told them? And then if they say my pronouns are something other than what's on the chart, and they say no, they don't know, I don't use it in front of the caregivers, because that would be in some cases dangerous, in many cases. So that's one thing that I do, but I have the privilege of separating caregivers and patients, but I actually think it's important. And then I have been in the situation very rarely where a patient will say, oh, actually, like, I've been wanting to tell them, but I don't really know when or how. And I'll say, well, like, if you want, I can be in the room with you, and I'm happy to do that. And sometimes I'll do that as well. But so those are some of the things I do.
Okay, moving on to the next question. Thank you so much, Dr. Cohen. The next question is, and this is for everyone, what is the best way to address a LGBTQIA+ patient who has had a bad experience in healthcare in the past? How do you regain their trust to optimally treat their health? And Rory definitely touched on this, but anyone is, can answer this.
So just to clarify, this is if you know somebody has had a bad experience in the past, how to create a corrective experience, or how to approach that. Right? That's understanding it.
Yeah, I think it's for people who have had bad experiences in the past, and then if you've also witnessed it as a healthcare professional.
Oh. So,
Like
so if
stories
you're,
witnessed from others, yeah. They
oh,
weren't specific who the question was for, so anybody
Okay.
who has had an experience with this can answer.
So I guess some of the basic tenets of trauma-informed care are, frequent check-ins, saying, how are you feeling about this? And giving them, like, whenever possible, when if you can give them a choice to do, to do either whether it be do a test or and to specifically tell them that their rights and responsibilities as patients, and allow them to play a role in planning or evaluation, asking, what do you think? And potentially even acknowledging, the fact that they might not have had the best experience, and emphasizing that, you communication, that you want them to be able to say no, as people were saying before in the presentation. I don't know if it's possible to do like a pre-encounter assessment, like you do post-encounter, you do post, like you give your patients surveys to fill out about their experiences afterwards, but leaving a spot, like, is there anything about your previous care that you'd like to discuss or that concerned you? And sometimes they might feel more comfortable writing it down and bringing it up in person.
yeah, so, right, I work as a therapist, so it's different than all of you. But I think if I'm lucky enough for them to tell me, which I do think it's a gift if someone tells me, I acknowledge that, again, I might look like people who have done those things. And I actually say this to everybody, but I think especially I say, I don't expect trust to happen in our first visit. Research actually shows it takes 2 to 5 visits for there to be a real bond and trust to build between a therapist and their client. And I think that's the most important thing when it comes to change or therapeutic growth, is the relationship. So I'm here for it, and that's okay. Let's take this at your pace. Like, I'm going to meet you where you are. And as therapists, we use self-disclosure really sparingly. It's really only if it's going to benefit the client. And so sometimes, and not across the board with every, non-hetero, gender binary, conforming person. But when I feel like it's therapeutically will be helpful, I will say, I will identify, myself. Because I think it's important, it's important for people to, because this is for some of us invisible, and it's not this, I don't wear it. So I think that's just really important, and being patient and affirming and saying, I'm also very open to feedback. Listen, I might say something that doesn't sit well, or I might, we might be talking about, and so tell me, and let's course correct. Again, if someone tells me like, that didn't sit well with me, that's a gift because some people just won't come back. So I think that I'm very open about that, and yeah, just try to create a safe, a space where, like, listen, I'm here for it. Like, I'm open to whatever you have to say. Let's check in, see how things are going. I think checking in is really important.
Yeah, I think a lot of those answers kind of answer our last question, which is a question in the chat. Someone asked, What are important ways or things to say to make patients in the LGBTQIA+ community feel safe and cared for during their patient visits? So if anyone wants to answer that and add on.
I think it can be really simple, right? It can be like, hi, my name's Dr. Kristen Birch. I use she, her pronouns, or, like stuff, kind of just using inclusive language. I think, even where's the restroom? Okay, well, there's a men's restroom here, a women's restroom here, a gender, however it's labeled, right? All gender restroom here, regardless of how the person presents, right? And just like, so I think just and even in your, whether it's an intake form, right? Asking those questions, like I think multiple people have said, to show that, because I think even an intake form can make someone feel like, oh my gosh, now I have to write this in, like I got to write my name on top because it's not, it doesn't match with my legal ID name. So I think just things like that. Yeah, and I think when you use inclusive language, it's free of assumptions, right? Like, do you have, are you, even like partners, right? Some people may have multiple partners, and so not make, I think thinking about like those kinds of things, and just mentioning that when you ask questions, I think just that very beginning can do a lot, can go a long way.
I think one thing for people who are still learning, which we're all still learning, is to like just kind of practice when you make a mistake, when you'll make a mistake, because we all make mistakes. So like if I misgender one of my patients, or if I don't know, use the incorrect name, I will stop myself and say, oh, I apologize. And then I'll correct, it just takes practice, and especially if you're new to it. Yeah, and just kind of keeping in mind that sometimes that it's not the patient's job to educate you necessarily. It's nice when they do, but you got to do the work on your own also. And what, Duncan, you said in the chat, yes, 100% yes.
Well, those were all of the questions, and we're doing great on time. So I want to take this moment to thank all of you so much for taking time out of your busy lives to participate in this panel for our students here at Rowan. It was amazing. I really appreciated hearing all of your input and your experiences. So thank you. Allies in Medicine thanks you. Hope the students thank you as well. So, and that will be the end. If anyone wants to get in touch with any of the panelists, let me know and I'll ask the panelists if that's something they want to share, but just reach out to me. And then Diversity Week continues until tomorrow, so check out more events on the DEI website for events going on tomorrow. That will be the last day of Diversity Week. So thank you all so much, and have a great night.
Thanks, guys.
Thank you. Have a good night, everybody.
Thank you guys
Thank
for your
you.
time.
Of course. Thank you.
Hey, Jess. Can you hear me?
Yes, there's still a few attendees on, so let me just, did you have something you wanted to share with me? more privately, or there's 2 attendees on. So
Oh, I was just gonna tell you did a great job. Yeah, very proud of you. You guys did great.
thank you.
And I was wondering if you're planning on sending
Oh
a
wait,
thank
let
you.
me, one second.